When a patient presents with a blood pressure exceeding 180 over 120, the difference between an urgency and an emergency comes down to one clinical factor: acute target organ damage. The brain, kidneys, or heart are failing right now. This is an active physiological collapse. An asymptomatic patient with high pressure can often be managed with oral medications in a clinic, but active and organ ischemia requires immediate, specialized intravenous intervention. To stabilize the patient, we need to execute 3 distinct steps: calculate the exact safe limits for pressure reduction, pace the speed of that drop, and select the correct intravenous medication for the specific organ under attack. Deviating from these parameters can easily turn a salvageable situation into a fatal ischemic event. Let's walk through the protocol. Step 1 is securing the right environment. A patient in a hypertensive emergency requires immediate admission to the intensive care unit. Once in the ICU, place an arterial line. You cannot rely on a standard intermittent blood pressure cuff to manage this condition. We are about to administer highly potent, fast-acting intravenous vasoactive drugs. A standard cuff only gives you a snapshot every few minutes. In the gaps between those readings, the pressure can drop completely out from under you. Before you even think about pushing medications to manipulate cardiovascular pressure, continuous beat-to-beat hemodynamic data must be locked in. Now we establish the target for the first hour of treatment. Calculate the patient's mean arterial pressure, or MAP. Your absolute maximum limit for reduction is 25% of that initial MAP. Do not attempt to immediately normalize the patient's blood pressure to a textbook 120 over 80. A chronically hypertensive patient undergoes autoregulation. Their vascular system permanently adapts to long-term stress. The vessels become tightly constricted, which means they actually require a much higher baseline pressure just to maintain normal blood flow. If you drop the pressure too fast, you remove the driving force pushing blood through those narrow vessels. This abruptly starves the brain, kidneys, and heart of oxygen, directly causing a secondary stroke or myocardial infarction. You are decelerating the pressure, not correcting it. A controlled, measured descent protects organ perfusion. With the reduction target set, we select the medication. In a hypertensive emergency, you do not choose drugs based on personal preference. The specifically damaged organ dictates the exact short-acting IV medication. Let's consult the matrix. For patients presenting with hypertensive encephalopathy, the preferred agents are nicardipine or labetalol. These preserve cerebral blood flow. If the patient is suffering from acute heart failure or pulmonary edema, transition your focus to the cardiac pathway. You need to push IV nitroglycerin or nitroprusside to reduce preload. For vascular complications like an aortic dissection, your immediate priority is heart rate control to reduce shear stress on the aorta wall. Use esmolol or labetalol. Aortic dissection presents the single critical exception to the 25% rule. For this specific condition, you must abandon the gradual descent and plummet the systolic pressure below 120 millimeters of mercury as fast as possible. Aside from that exception, the framework holds steady. You are treating the failing organ, not a generalized blood pressure number. Once the first critical hour has passed, the goal shifts. Over the next 2 to 6 hours, begin gradually adjusting the IV drip to reach a target of approximately 160 over 100. During this titration phase, verify that the organs are receiving enough oxygen. Monitor the patient's mental status and track urine output. These are reliable clinical markers of adequate perfusion. The final phase requires patience. Wait until the patient has maintained cardiovascular stability for a full 24 hours before you attempt the transition to oral antihypertensive medications. We only consider the emergency phase fully resolved when the patient proves they can safely maintain healthy perfusion entirely without intravenous support. By holding strictly to the math and the timeline, target organ damage is halted, and the pressure is successfully walked down without triggering secondary ischemia. Let's lock in the 3 rules. Rule 1. Mandatory ICU admission with continuous arterial line monitoring. Rule 2. A strict maximum 25% reduction in mean arterial pressure during the first hour. Rule 3. Always match the specific IV medication directly to the specifically damaged organ. With the patient stabilized, your diagnostic focus shifts. You now have the time to investigate and identify the underlying root cause that triggered the crisis in the first place. Relying on this concrete framework takes a highly chaotic, high-mortality presentation and turns it into a controlled, survivable process.